Hello everyone. Diuretic class of drugs are a major part of all our prescription in our day-to-day practice. So different diuretics we use for different indications, and it's not only those patients with the end-stage cardiac problem or end-stage renal problem, but the major prescription for diuretics we use is to treat hypertension. In last few years, we have heard lot of discussions, lot of debates, lot of dilemmas about thiazide and thiazide-like diuretics. So we have decided to discuss the basic mechanism of action of different diuretics today in the today's session of Diabetes Dilemma. I am Dr. Shailaja Kale from Diabetes Dilemma, and with me today is Dr. Valentine Lobo, a famous academically oriented nephrologist from Pune. So welcome Dr. Lobo to Diabetes Dilemma session. So today we are discussing different diuretics which we use in our day-to-day practice. As we discuss where exactly in these drugs act, in which part of the nephron or the tubule, to understand the effects and the side effects, will you please explain different class of diuretics and the basic sodium water handling by a nephron and how these diuretics act? So I think we are just revisiting these basic mechanisms of different diuretics and also the sodium water handling in kidney.
Cannot understand the action of diuretics unless we understand how the nephron handles salt and water. The tubular filtrate or the glomerular filtrate which enters the proximal tubule has the same constituents as plasma, since it is a filtrate of plasma. So it contains sodium, bicarbonate and chloride and also water in the same concentrations as found in the plasma. Now once the proximal tubule, in this section, under the action of carbonic anhydrase isoforms 2 and 4 and the sodium hydrogen exchanger 3, a large amount of sodium, bicarbonate and water, about 65 to 70% of the components of the filtrate are absorbed. Because both sodium and water are absorbed, this section of absorption is called isotonic, that is the fluid entering the proximal tubule and that leaving the proximal tubule has the same osmolality as that of plasma, namely about 280 to 300 milliosmoles per kg. Now once this tubular fluid leaves the proximal convoluted tubule and enters the loop of Henle, it enters the descending limb of the loop of Henle, which is impermeable to salt and water but is freely permeable to water. So as water gets absorbed, the fluid descending in the loop of Henle becomes steadily more concentrated, reaching from about 300 milliosmoles per kilogram where it entered to about 1200 milliosmoles per kg at the hairpin bend of the loop of Henle. We know that there are both short looped and long limbed loops of Henle, and it is the long limbed loops of Henle which concentrate the fluid maximally to 1200 milliosmoles per kg. Now as the fluid then turns and enters the ascending limb of the loop of Henle, a significant portion of this part of the loop of Henle is known as the thick ascending limb of the loop of Henle, and it is impermeable to water. It is however permeable to sodium, potassium and chloride, and this is mediated largely through a transporter called the sodium potassium 2 chloride channel, which is inhibited by loop diuretics, furosemide, torsemide and bumetanide. Now in the absence of the diuretics, again about 15 to 20% of the sodium and chloride is absorbed in this section with some amount of potassium of course, and as we saw, 65 to 70% was absorbed in the proximal convoluted tubule. Now we have an additional 15 to 20% being absorbed, but there is a difference. In the proximal convoluted tubule, both sodium, chloride and water absorbed, so the fluid did not change its osmolality. At the first time in the nephron, we have a dissociation of water and salt absorption. So we have a section in which sodium and chloride is being absorbed, but water cannot be absorbed. So the fluid, which had become concentrated in the descending limb by absorption of water, now begins to get diluted. In fact, it becomes even slightly more dilute than that of the original ultrafiltrate of plasma. So as it enters the connecting segment, which was formerly called distal convoluted tubule, this connecting segment receives a tubular fluid which has an osmolality of about 200 to 250 milliosmoles per kg. Within this section, the connecting segment is a sodium chloride co-transporter which is inhibited by the thiazide and thiazide-like diuretics. Now, the remain already about 85% of sodium and chloride has been absorbed, and here an additional 5 to 10% will be absorbed in the absence of inhibition, and so the tubular fluid becomes even more dilute. So this segment is often known as the diluting segment of the nephron, since the osmolality under the influence of the absorption of sodium and chloride drops further, reaching about 50 to 100 milliosmoles per kg. The lowest value that can be reached is about 50 milliosmoles per kg, and this is the maximum dilution of urine that can be achieved by the nephron in the presence of a significant water intake. Now, as the tubular fluid then enters the cortical collecting duct, there is an epithelial sodium channel which is sensitive to the effect of aldosterone. It's important to remember that the epithelial sodium channel is at the luminal border of the principal cells, whereas the aldosterone receptor is at the basolateral membrane, and it requires a signal transduction through the cell. So, drugs which inhibit aldosterone will act at the basolateral membrane, that's spironolactone and eplerenone, while drugs which inhibit the epithelial sodium channel like amiloride act at the luminal border here. Now, when sodium is absorbed under the influence of aldosterone, potassium is secreted in this segment, and so the nephron at this stage absorbs sodium while secreting potassium, and also in the absence of potassium, a certain amount of hydrogen ions are also secreted. Once the fluid passes further into the collecting duct, this segment of the collecting duct does not have any more channels to absorb any of the ions, and under normal circumstances is impermeable to water. But in the presence of arginine vasopressin secreted from the posterior hypothalamus, certain proteins called aquaporins, namely aquaporin 2, are inserted into the luminal border of the membrane in these cells of the collecting duct. Now, we have to remember that on the other side is the interstitium, which has received the large load of absorbed sodium and chloride from the loop of Henle. So, the medullary interstitium here is highly concentrated, up to about 1200 milliosmoles per kg, and when this segment of the collecting duct becomes permeable to water, then with a hypertonic medullary interstitium drawing water and a segment of the tubule which is permeable to water, under the influence of arginine vasopressin, large amounts of water can be absorbed and the urine will get concentrated, or the tubular fluid which goes on to form the urine gets maximally concentrated here to about 1200 milliosmoles per kilogram, which corresponds to the minimum amount of water that is required to be excreted in this situation, about 400 ml in an adult human being. So that is why 400 ml of urine is the minimum that can be passed. Below that, we call it as a pathological condition of oliguria.
Yes, I think, thank you. It's very nice to revisit the basic concepts, and so can we have some your views about different thiazide and thiazide-like diuretics? Is there a difference between hydrochlorothiazide, indapamide, chlorthalidone in their basic action, or maybe when we call duration of action or anything?
Right. So, the thiazide diuretics originally are those which contain the thiazide ring, and chlorthiazide was the initial one. Hydrochlorothiazide also belongs to that group. Metolazone is a bit in a class of its own. It has some specific properties, namely its ability to also inhibit carbonic anhydrase and act on the proximal tubule, while chlorthalidone is a thiazide-like diuretic, but it also has some very interesting properties. So, as far as structure is concerned, chemical structure is concerned, these might be called thiazide or thiazide-like diuretics, but they act on the same sodium chloride co-transporter in the same segment, the connecting segment of the nephron. As far as their individual properties are concerned, hydrochlorothiazide has a shorter half-life, about 8 to 12 hours, whereas chlorthalidone has a long half-life of about 20 to 30 hours, which allows a once daily dosing and makes it an ideal drug to use as an antihypertensive. Metolazone has some interesting properties. It is not a very powerful diuretic on its own, but it has a remarkable ability to potentiate the action of all the loop diuretics, and also it is the only drug in this class which can act in the presence of a following GFR. It is active until a GFR of about 30 minutes, whereas most of the other thiazide diuretics and thiazide-like diuretics will lose their action in the presence of chronic kidney disease.
Yes, so also I want to know about this, your comment about this hypokalemia and these thiazide diuretics, and because there is so much of which we will discuss again, can I have your comment about this?
Right. So, hypokalemia is associated with the thiazide diuretics and also with the loop diuretics. Where the loop diuretics are concerned, it's easy to understand. They are inhibiting the sodium potassium 2 chloride channel. So, absorption of all of these will be inhibited and these will be lost in the urine. Sodium, potassium and chloride. But with the thiazide diuretics, there is no potassium in the channel mentioned over there. So, the mechanism by which the thiazides and thiazide-like diuretics cause hypokalemia is an indirect mechanism. They deplete the intravascular volume, and as a result of this, what happens is that aldosterone secretion is increased, and we know that aldosterone is responsible for sodium absorption and potassium secretion. In addition, they increase the distal fluid delivery to that segment where sodium is absorbed by the epithelial sodium channels, and we know that in this section also potassium is secreted by the principal cells and the intercalated cells. So, the indirect effect of thiazides, increasing the aldosterone concentration and increasing the distal fluid delivery to that section where aldosterone will act, is responsible for the hypokalemia that is seen with these drugs.
Yes, and you also mentioned that chlorothalidone, because it's a long acting drug and the drug lasts for 24 hours, it becomes a preferred thiazide-like diuretic when we treat hypertension. Yes. And sorry to use the word Lasix and Ditor, but I think we understand better when we use these words. What's the difference between the furosemide and the torsemide when you come to mechanism of action?
The mechanism of action is the same. They both act at the same site. The important thing to remember about Lasix and Ditor or furosemide and torsemide is that they need to reach the tubular fluid because they act at the luminal border. So, there are specific organic ion transporters 1 and 3 which are responsible for delivering them to the tubular lumen. They act at the same point, but as far as the potency is concerned, torsemide or Ditor is twice as potent as furosemide. So, the dose needs to be halved. So, an equivalent dose would be 10 milligrams of torsemide is equivalent to 20 milligrams of furosemide or Lasix. The other difference is that the oral bioavailability is significantly different. Furosemide has very variable oral bioavailability, varying from 6% to more than 50%, whereas torsemide is more stable. It is absorbed to the amount of 50 to 80% after an oral dose, and so it would be the preferred oral drug, whereas either of them could be chosen for intravenous use.
Yes. And what about these potassium sparing diuretics, which we use in very end stage kind of a problems, whether cardiac or the renal? But are there any other indications, some new research? Can you comment on that?
So, there is significant benefit about the potassium sparing diuretics. Among these, spironolactone and eplerenone. Eplerenone has less side effects because it is selective to the mineralocorticoid receptor, does not interfere with the androgen, whereas spironolactone has a lot of troublesome side effects because of the cross reactivity. Now, spironolactone and eplerenone have been used very successfully in the treatment of cardiac failure, and also they have been shown to have a good long-term prognosis. They also might be combined with the loop or thiazide diuretics to prevent the potassium loss that we mentioned a few minutes earlier. Finally, spironolactone is particularly effective, even more than the loop diuretics, in taking care of the ascites of cirrhotic patients. So, that is a particular use where spironolactone is more effective than loop diuretics. There have also been studies which have now tried to use these drugs in retarding renal fibrosis, which has been linked to mineralocorticoid excess as a compensatory mechanism. So they have been shown to reduce renal fibrosis. The caveat to this is that they are potassium sparing, and as renal function decreases, there is a propensity to hyperkalemia, so they have to be used with extreme caution and close monitoring. Also, many of the patients with chronic kidney disease will be receiving other nephroprotective agents like ACE inhibitors and angiotensin receptor blockers, which also increase propensity to hyperkalemia. So if combined with a potassium sparing diuretic, extreme caution is required to prevent a life-threatening hyperkalemia.
So I think it was a very good kind of a revisiting the basic mechanisms of different diuretics, revisiting the nephron and the different parts, and how the sodium and water handling happens, and wherever all these diuretic drugs we are using, how it acts. So it was just revisiting our basic concepts, and thank you so much,
Thank you.
Valentine Lobo. Yeah.